Welcome to Best of the Day. I'm at the 14th International Myeloma Workshop in Kyoto, Japan. I'm Dr. Sagar Lonial from Emory University in Atlanta, and I'm joined today by Dr. Cavo from the University of Bologna, and we're going to talk a little bit about consolidation and maintenance therapy and some of the data presented at this meeting. Welcome, Dr. Cavo.
Thank you.
So let's talk a little bit about, I think, a concept that's really the Europeans have led us on, and that is the idea of consolidation after transplantation. What are some of the data that's being presented, and how can we use this in our daily care of patients?
Consolidation is by definition short-term therapy and is aimed at increasing the rate and possibly the depth of a complete response after transplant. The novel agents have been introduced into the autotransplant sequence over the last 10 years and have dramatically improved the outcome of transplant-eligible myeloma patients. Based on the highly activity shown by novel agents as part of induction before transplant, the same agents have been widely investigated also as part of consolidation after autologous stem cell transplantation. Several years ago, we designed a phase 3 trials that was aimed at comparing bortezomib combined with thalidomide dexamethasone VTD versus thalidomide dexamethasone as induction before a double autologous stem cell transplantation. By study design, patients who were initially randomized to VTD or TD arm of the study received 2 additional cycles of the same triplet or doublet regimen as consolidation after double autologous stem cell transplantation.
And when did they receive the consolidation in your study?
They did receive consolidation approximately 3 months after the second transplant.
Okay.
We, several years ago, published the results of an intention to treat analysis demonstrating the benefit offered by VTD in terms of increased rate of complete response translating into an extended progression-free survival. To try to better understand the role of consolidation into the entire treatment program, we perform a per-protocol analysis of more than 300 patients who received all the treatment phases. And it was interesting to note that the per-protocol analysis that by definition excluded all the patients who did not receive consolidation excluded the great majority of patients in VTD who had already in a CR or near CR. And due to this reason, in the per-protocol analysis, the rate of CR was similar between the 2 treatment phases, differently from what we previously observed on an intention to treat basis. Right. Interestingly, after 2 cycles of VTD, the rate of CR was significantly higher with VTD in comparison with the TD. Approximately 30% of patients who were not in CR before VTD consolidation upgraded to CR after consolidation, and the great majority of these patients were already in VGPR or near complete response. We also performed a landmark analysis from the start of consolidation, which showed a significantly extended PFS for patients receiving VTD in comparison with those receiving TD consolidation. The superior activity of VTD versus TD in terms of higher rate of CR and extended progression-free survival was retained also across a subgroup with high risk and was confirmed also in a multivariate analysis. Therefore, the conclusion of the study was that the triplet regimen retain the same activity previously shown as induction, and that consolidation was a major part of the treatment program, and that consolidation significantly contributed to the improved outcome we had previously observed on an intention to treat basis.
Right, right. I mean, I think that the study that you mentioned was really quite striking for a number of reasons. It did, I think, highlight the importance of consolidation. It also, and I think you raised this point early in your description, in the U.S. there are many physicians who are questioning the timing and role of transplantation. And I think your introductory comments about novel agents enhancing the efficacy of transplantation is a really important point, because all CRs are not the same, right?
Sure.
And so what are some methods that you all are using to assess different types of CRs to prove just that point?
Yeah, we performed a sub-analysis aimed at evaluating minimal residual disease by molecular techniques, by patient-specific primers. And what we observed was that the higher activity shown by VTD in comparison with TD was also reflected in a higher probability to achieve a molecular complete response. And you are completely right when you state that not all patients in CR are the same. We have proof of principle coming from studies of MRT detection by flow cytometry, and also using imaging techniques. For example, we showed that patients with PET positivity and in CR after transplant have an outcome significantly better in comparison with patients in serological CR but with the PET positivity. The concept of CR is imperfect in myeloma. It equals to many logs of residual myeloma cells, and due to this reason, my personal feeling is that consolidation plays an important role in deepening the level of response and in improving the quality of response.
Yeah, yeah, and I think the other point I often take away from your study is the idea that not being content with a conventional CR, using consolidation and then maintenance strategies afterwards allowed you to take 414 patients that were previously considered to be high risk and make them look more like standard risk patients.
Yeah. This study, as well as other similar studies using or not consolidation, but all of them, including bortezomib, as part of the transplant sequence, do suggest that patients with the T414 treated with bortezomib incorporated into transplant have an outcome very similar to that of patients not carrying this abnormality. We may discuss if bortezomib-based transplant is able to improve or to completely overcome the poor prognosis related to T414, but it's certain that in the context of a bortezomib-based treatment, T414 is at least an intermediate risk cytogenetic abnormality and not a high-risk abnormality.
Right, okay. So your study certainly was one of the landmark studies in terms of consolidation. What are some other approaches in Europe predominantly that addressed consolidation that I think are worth discussing?
There are other studies exploring the novel agents as part of a consolidation after transplant. There is a phase 3 study. In that study, patients were randomized to receive bortezomib as single agent versus not consolidation, and results showed that the bortezomib arm was associated with a significant significant improvement in the rate of at least the VCPR, and again, this translated into an extended progression-free survival. Another possibility to combine bortezomib with the NIMID is to substitute thalidomide with the lenalidomide. VRD or RVD was used as induction before and consolidation after transplant in another European trial, and again the results showed that after consolidation there was an improvement in the rate of high quality responses, and the same improvement was seen when lenalidomide was used as a single agent before randomization to receive lenalidomide maintenance versus no maintenance. All these studies do support the role of consolidation as a part of the autotransplant sequence, although before recommending consolidation as a routine clinical practice, we need to have the proof of principle of the use of the benefit of consolidation coming from phase 3 clinical trials. And one of these studies here is currently running in Europe. The first study endpoint is to evaluate the role of transplant upfront versus transplant delayed at the time of relapse, and the second endpoint is to evaluate consolidation versus non consolidation. And in this study, consolidation includes bortezomib, lenalidomide, and dexamethasone.
So if you were seeing somebody that wasn't going on one of your clinical trials, how would you decide what kind of consolidation to offer them? Would it be 3 drugs? Would it be 1 drug? Would it be thalidomide or lenalidomide based? How would you sort that through, presuming you could give whatever you wanted?
We have not had to have a clinical trial. However, if you try to compare the results coming from phase 2 and phase 3 clinical trials, again, the idea is that 2 drugs are better than 1. This is the reason why my personal feeling is that combining a proteasome inhibitor with an immunomodulatory agent, again, as already shown in the induction phase, is associated with an improved outcome with a better high quality response rate.
Okay. So I think you know, the concept of introducing consolidation to routine care, certainly in the U.S., is not something that's hit yet, but I think there are many compelling trials that you've just described using either VTD, single agent lenalidomide, or VRD as consolidation after autologous transplant. What about the maintenance phase? So there are a number of trials looking at maintenance. Where do those fit in?
Many trials exploring thalidomide, a few trials exploring bortezomib, 2 important trials exploring lenalidomide. Thalidomide has an impact in terms of extended progression-free survival and overall survival. The major limitation is neurological toxicity. Due to this reason, thalidomide is not widely accepted as maintenance after autotransplant.
What do you think about this data from the British group suggesting that among high-risk patients, thalidomide may make things worse? Do you think that was a unique finding, or do you think do you think thalidomide and perhaps even maintenance in those patients is not a good idea?
All data so far available do support the notion that thalidomide is unable to overcome the prognosis related to any cytogenetic abnormality, even related with 13q deletion, that at this time is not more considered an adverse cytogenetic abnormality. I was discussing about lenalidomide because due to the ease of of oral formulation and the lack of neurological toxicity, lenalidomide is probably the ideal agent to be used as maintenance. We have two large phase 3 trials evaluating lenalidomide as maintenance after autologous stem cell transplantation. In both of them, a dramatic improvement in progression-free survival, approximately in the 42 months after the start of lenalidomide maintenance. In one of them, also an overall survival benefit. There is a study, an European study, comparing bortezomib as a single agent versus thalidomide as maintenance after autologous stem cell transplantation, and the results do support the superior activity of bortezomib along with its better toxicity profile. In this study, as well as in other studies using bortezomib as maintenance, bortezomib is given once weekly or even bi-weekly, 2 times every month. However, again, there is the need of an intravenous infusion, and it may be that the oral formulation may be preferred by the majority of the patients.
So what do you think about the studies that you're currently using? Are you using IV when you use bortezomib as maintenance, or have you switched to subcutaneous dosing?
Switch from the intravenous to the subcutaneous formulation.
Yeah. So there are many, certainly in the U.S., that are debating this maintenance len versus no maintenance lenalidomide question. And the skeptics will often say overall survival was only shown in one trial. What do you think accounts for differences in outcomes? PFS is almost identical between the CALGB and the IFM study, yet there were other differences between the studies.
Yes, the two studies are very different. For example, in the French study, there was a consolidation phase before randomization. In the US study, no randomization. The number of agents, most of the patients enrolled in the French study were previously randomized to a standard VAD induction chemotherapy versus bortezomib combined with dexamethasone. In the US trial, many patients did receive novel agents as part of induction. So I think that probably we need more time. I agree that in the maintenance setting, an overall survival benefit, or at least a trend suggesting an overall survival extension along with the quality of life are two major issues to be taken into consideration before maintenance can be widely accepted.
So the other issue that often comes up is quality of life and second primary malignancies. Where do you fall on that on those issues?
Up to now, we have no data coming from the two studies related to a quality of life evaluation. The issue of SPM was quite similar with several differences between the two studies. For example, in one study, suspected increase in the incidence of B-cell malignancies, not confirmed in the other study, but in both of them probably SPM was not a major issue, and the benefit offered by lenalidomide did outweigh the potential risk of SPM that needs to be taken into proper consideration. And due to this reason, it is important before starting maintenance to discuss with the patient about the pros and cons of lenalidomide maintenance.
Yeah, I completely agree. And one of the things that we try and do at our center is tailor the maintenance based on risk. And so patients with high-risk disease may get a different maintenance schedule than standard risk. How would you approach currently somebody with high-risk disease, not 414, but one of the other?
In Europe, the landscape is different because lenalidomide is not approved as part of maintenance, and due to this reason in many European centers maintenance is not applied outside clinical trials. However, I agree with you that if you want to try to dissect the patients between those who are more likely to benefit from those who in whom this treatment option should not be taken into consideration. The issue of response is important, although I would like to remind that in the French trial the benefit in terms of extended progression-free survival was seen also in patients who were already in CR before starting maintenance. And this is particularly relevant because in the previous study with the thalidomide improved the outcome only for those patients who failed to achieve a very good partial response. In that study, thalidomide worked more as consolidation rather than as maintenance. However, it is likely that patients at higher risk of relapsing, patients with high-risk cytogenetic abnormalities may benefit from lenalidomide maintenance, and a sub-analysis of the French studies show a significant progression-free survival benefit for patients with the T414, for example, in comparison with the same group of patients receiving placebo in terms of extended progression-free survival with lenalidomide maintenance.
Right, right. So it sounds as though the planned treatment program concept has really been a part of what's made a difference. So the days of 4 cycles or 6 cycles of treatment X and you're done, or 4 cycles or 6 cycles of treatment of transplant and you're done, are gone. Is that?
The major issue is probably related to the prevention of the risk of a relapse in patients with the really high-risk cytogenetic abnormalities, for example, 17p. In this setting, there is a lack of robust data supporting the ability of any of the novel agents to improve or overcome, although results are quite conflicting with the use of bortezomib as part of the transplant sequence. A single trial showing a potential benefit, other trial not showing an improvement in the outcome. Probably we need more data, and due to this reason in Europe a risk-adapted approach is not widely accepted due to the lack of prospective clinical trials evaluating the role of different more intensive versus less intensive treatments in patients at a standard risk or at high risk.
Yeah, yeah. So to sort of wrap up then, what are the future directions of maintenance and consolidation? Using new drugs, using them for longer, using them for shorter, antibodies, how would you design your perfect trial?
My personal view is that both consolidation and maintenance are complementary and are two important phases of the autotransplant sequence. Obviously, several questions still remain unanswered. For example, do we need to use consolidation in all the patients or in particular subgroups of patients? And in these patients, for example, an evaluation of a minimal residual disease before starting consolidation may be of value in choosing if using or not consolidation. Regarding the use of maintenance, an important the question if is related to the length of maintenance therapy. Maintenance should be given until relapse or progression, or maybe used for a fixed time period. And several trials currently running use lenalidomide, for example, for no more than 2 years as maintenance. However, there is a lack of phase 3 clinical trials in which patients were randomized to a novel agent until relapse or given for a fixed time period.
Right. Yeah, lots to do. It's exciting.
Yeah.
All right. Well, thank you. You just heard the first of the best of the day from the 14th International Myeloma Workshop. Please tune in again to hear the rest of the updates over the next 3 to 4 days. I'm Sagar Lonial, and joined today by Dr. Cavo. And thank you, and we'll see you tomorrow.